When I started at WHO working in 1998, hepatitis was not at all on the agenda. I moved into the HIV department, and as we rolled out antiretroviral therapy, we found that liver disease was going to be a problem for many of the patients, particularly those who injected drugs, because of the large co-infection. We didn't know how many were co-infected. We always said many people, and being at WHO, you need the facts. So I found the topic of my PhD to study HIV, hepatitis co-infection. So I left WHO for a little while, worked on those issues, came back and was approached by a newly formed group called the European Liver Patients Association. You have a member here in France. And they said, we'd like to raise awareness about hepatitis C. Would you partner with us? So we organized the first World Hepatitis Awareness Day in our office. It was maybe as many people here at the global day. And we made these little pocket magnifying glasses, which luckily I found in some box a few years ago. And it says, 2006, get tested. And during the talks of the different directors of EASL, head of ELPA, and so on, we would hold them up and say, where is hepatitis in the global policy documents? Where is hepatitis on the WHO agenda? And I was thinking more or less, where is everybody? Because with all respect, there weren't many people, maybe 50, 60 people at the Global Hepatitis Day. And that's all changed, as you know. That's changed because of the new medicines that came onto the market in 2013 and really started to expand these last couple of years. So that's meant a big change for us. In 2007, I was at the International Liver Congress of EASL, and for me there was really nothing interesting on the agenda from a public health perspective. They'd never had a public health session on viral hepatitis. They'd never had a single policy session or presentation on viral hepatitis. We met together with the patients outside of the conference and founded the World Hepatitis Alliance, and then we went home and didn't even go back to the conference. It's changed quite a bit. Have any of you been to the International Liver Congress, to ILC? Okay, so it's changed quite a bit. Now there are elimination sessions, policy sessions, public health approach. Why? Because discussing sustained virologic response, SVR, is really not very interesting anymore when we have the clinical trials and the real-world data showing more than 95% of the population studied achieving SVR, and with modified intention to treat, sometimes as many as 99-100% of people are really getting they're cured. So the question at hand is really how to translate these good biomedical tools into good health outcomes for people living with hepatitis C. So I see this as really having two veins of study. The first is the biomedical, which we know we've achieved, right? There's no new drugs in the pipeline. We have pangenotypics that take 8 weeks. We have pangenotypics that take 12 weeks. We have others that aren't genotypic specific, but we have a whole range now of DAAs that can be used. Instead, we need to be thinking about why are they not being used? And these are the public health challenges. The challenges related to access, the challenges related to coverage. And then in some settings, we still have issues related to quality and safety, depending often in low and some middle-income countries with parallel imports, certain generics, or just certain settings where people are not being properly, let's say, reviewed for the medicines they're taking. So these public health challenges, the only way I really see achieving them or meeting them is by addressing the changes in the health system, so that if we can pay greater attention to health systems issues, we can overcome particularly the challenges of access and coverage. And I know that you have a large addiction research center here, that people who inject drugs is a main topic of focus and a main affected group in France, as in the rest of Western Europe. And these are the big challenges that population faces. Earlier this year, Lancet Gastro Hep, a relatively new journal, decided to put a spotlight on viral hepatitis, and for the first time, not really the clinical issues, but instead more of the public health and health systems issues. So they published a commission in early January this year, and the commission was really about how to accelerate the response in this elimination era. And here not because I particularly wanted to highlight these countries, just to show you an example by region. The Commission goes through the challenges, presents the burden, presents the different interventions that can be used to overcome the different obstacles that are faced. We know that there are countries like Egypt with an enormous estimated burden, Mongolia, Georgia, other countries that are high burden, and then across Europe we tend to be facing under 1%, often 0.5%, although that's much higher in particular populations like people who inject drugs, like those co-infected with hemophilia, some CKD populations, etc., etc. Another thing the Commission did, and this is a very busy slide, but I just circled France, if you can read it down here, was to create a policy index. And these kinds of indexes have mixed utility, but in general, using the red, orange, pink circle and white, it shows if the countries have the right policies in place to achieve elimination. And you can see, looking at France, it may say that under harm reduction, it's red, but we know that harm reduction still might not be widespread enough. It might not be in all of the cities and urban areas where drug users are. I was in Paris when the drug consumption center opened up, and there were lots of supporters of the DCR. There were also the signs saying "Ici non," and lots of protests about having a safe injection center. And of course, these aren't widespread throughout France or really anywhere in the world. So even when we say a country has harm reduction because they have opioid substitution therapy, they have needle and syringe exchange, or they might have drug consumption rooms, it doesn't necessarily mean that the coverage is widespread enough. So this is useful because it shows countries that at least have that possibility and then need to work on coverage and access. And then, of course, it shows countries that really have, nothing at all. Lots of the Middle East, but also Hungary, some parts of Europe. So if you take a look at the Commission, you can really see what's happening around the world, what's happening in Europe, and some of these solutions that the commissioners and colleagues came up with. So earlier, as I mentioned at an International Liver Congress, we would be spending all of our time talking about SVR and the challenges of SVR and why SVR is so low. But with the pangenotypics, we really move into an elimination era, and now we're starting to see presentations like this one where we will not really talk about SVR at all and instead focus on public health issues. So goodbye to that. Instead, hello to the new political will to eliminate viral hepatitis. I mean, we've come a long time from this magnifying glass, except as you know, on the magnifying glass it says 2006, get tested. If we change that to 2019, it would be entirely relevant as well. I'll show you in a moment the continuum of care that WHO put forth, and we know that one of the big challenges, it's kind of like the world in reverse. Now, when people are diagnosed in many of our countries, they're getting their treatment and they're getting good outcomes. Instead, the problem now is diagnosing people and finding people. So it's a very different situation than just a few years ago when we had the so-called warehoused population, when the hepatologists and other specialists could say, we really don't need to do much because we have so many patients to treat. And suddenly in parts of Spain, across Australia, parts of Denmark, et cetera, we're saying, well, where are the patients? Suddenly we've treated everyone, and this is a completely new situation for hospitals. I don't know if it's the case here. If not, it will probably be so soon, because why not just treat everyone? Certainly in France, where you have universal access, and you've had that ahead of many other countries. But going back a little bit in time, in 2010, the first World Health Assembly resolution on hepatitis was passed. So the World Health Assembly met last week. That's the highest governing body in health and governs the World Health Organization. And in 2010, that resolution basically recognized World Hepatitis Day. That was as good as we could hope, to recognize a day when an official disease day like AIDS, tuberculosis, malaria, and today, which is, anybody know what today is? Yeah, in terms of world days. Well, Patricia and I were joking about it before because we were in a no-smoking cafe and all the smoke was coming in. So today's World No Tobacco Day. So we see how successful these days are doing, right? Hepatitis is not even close to as well known as World No Tobacco Day. But if you're on Twitter, you can join the party. In 2014, the the second resolution gets passed. And this is important to remember. There's 2 resolutions here, but in terms of cancer, HIV, many other areas, there are many, many resolutions. 2014 said all countries should have a viral hepatitis strategy, and WHO itself should have a strategy. In 2015, the patients of the world meet for the first time. And this is a chance for more than 80 patient groups from around the world to exchange experiences, limited participation of clinicians, so it's kind of like the anti-International Liver Congress, where the patients and advocates get together and figure out what do we need to do to increase access and coverage. They met again in Brazil in November 2017. WHO was there, the government of Brazil, and other ministers from some countries. In 2016, the patients brought us the No Hep movement, so this kind of echoes the red ribbon that I'm sure you're familiar with. You're probably not so familiar with the No Hep logo, but now you are, and this is what they try to use to brand this approach to elimination. It's a different way of thinking, but we need to be, we need to be raising awareness and getting ministers to wear pins, et cetera, et cetera. And then in February 2016, elimination first came onto the EU agenda. So together with the Commissioner for Health and Untitled, leading clinicians, researchers, and patients, a manifesto is released calling for the elimination of hepatitis C in all EU member states. And 4 months after that, in May 2016, WHO announces its first strategy, and they called it for hepatitis. And they call it a global health sector strategy, recognizing that we can't approach hepatitis in a silo with a vertical program. We need to be thinking about elimination in terms of thinking about the health system as a whole. And learning from polio, learning from other diseases where there have been elimination efforts, they call for the elimination of hepatitis, but just to make our lives complicated, they call it the elimination as a public health threat. So of course all of us in public health wonder, how do you defining public health? Which definition is this? How do we understand this? Because if it was elimination, we know what that means in terms of epidemiology, reduction to zero through controlled efforts. That's probably too ambitious by 2030, but to try and get that mixture of visionary and ambition, but also reality, because it would be nice to see some success stories, they call for elimination. Here you have the World Health Assembly at the time of the presentation of the first strategy, and they call for elimination as a public health threat. They did give us some tools to define this. So you see here a series of specific targets around incidence. We know how hard that is to measure if we don't have a good baseline, which almost no country has. We have mortality targets, which are easier to measure if we know the attributable fraction, why people are dying of liver disease, what was it attributed to. A lot of countries are still struggling with that, including in Western Europe. It calls for prevention, specifically mentioning harm reduction. So we know UN has a comprehensive package of harm reduction, but in terms of hepatitis elimination, specifically needle and syringe distribution will be measured, going from an estimated baseline of 20 per person per year, which is not enough, to 300, which is still not enough, but at least gets us to what we think is sort of the elimination era. And then testing and treatment targets for 2030. So some targets will need to be measured already next year, and WHO has now launched 10 core indicators as a part of their monitoring and evaluation framework. But by 2030, we should be achieving these goals. I think a country like France should have more than 80% of the estimated population treated. This is in 11 years, and things are moving quickly. But, well, this is also relevant for low-income countries, be they in Asia, Africa, or Latin America. So this is the global goal for elimination. And we know from other areas, smallpox, polio, HIV, things really start to move when WHO puts these strategies into place and starts measuring progress towards achieving them. So I mentioned WHO also gave us this tool, this organizational tool, the continuum of care. We know this well from HIV, so you're familiar with the 390s, which is a modified version of this. And here in hepatitis, we move from the estimated prevalence to tested to those aware of their status. That seems like an odd column to have, but I don't know the situation in France, but in the Netherlands, Norway, Denmark, other countries, we're finding thousands, even tens of thousands of people who have been diagnosed in hospitals and lost to follow-up. So this is something you can look at here in this center and in other hospitals. They were deemed treatment ineligible, or they heard from their friends and peers that you really don't want to take pegylated interferon because of all the side effects, and they simply never came back. So while we're looking for patients, we also have databases in hospitals of patients who are lost. And that always raises the dilemma of who should make those phone calls? Who sends those letters? How do we reach those patients? That we can discuss later, but that's one of the big challenges we're facing at the two university hospitals where I work, because everyone says, well, tell the GPs. And the GPs say, well, we're too busy to start calling people to say, come in because 10 years ago you were diagnosed with a potentially deadly infection. It's a very tough conversation to have. It sounds easy just to say call them and tell them to come, but in reality it becomes more complicated, and you need to explain why there's been no follow-up until now. Ultimately, we aim for viral suppression, but WHO says the story is not over there. After cure, if people presented late, which we know is often the case, they will have presented with liver damage and they need regular follow-up. So we need systems in place to monitor these people post-SVR. We tend to say, you no longer have hepatitis C, you've been cured, they go home, but a lot of people need continued follow-up, or they need support to prevent reinfection if they're active injecting drug users. So one of the things we're doing in our group is looking similar to the 390s, where we put forward this idea of a fourth 90 related to quality of life. We're looking at how to reduce the continuum of care more for reporting, to improve reporting. So we're looking at the Kirby Institute's work, where they have very detailed data on viral hepatitis, and trying to think, well, what would be to define the 4 columns so that every country in the world can report back. So we came up with these definitions. I won't go through them all but I'll leave the slides, or you can see it in the ILC abstracts. The article will come in SID soon. But essentially, when you say diagnosed, do you mean antibody diagnosed, or do you mean RNA diagnosed? And countries are using this often interchangeably, and yet we know that the population with RNA will be a lot less than those with antibodies. When we look at treated in a particular year, what happens if you initiated treatment at the end of one year and were cured the next year? And there's a lot of confusion and double counting and so on. So one of our jobs in public health has been to try and bring order to the continuum of care. And then we started piloting it in the Nordic countries. We thought in these high resource countries it would be fairly easy. Instead it became quite a challenge, but an interesting process. And in countries like Sweden, this is not working, we see a relatively large percentage is diagnosed, but then most aren't treated. In Denmark it's much lower diagnosed, but then most of them are treated. So this becomes a useful tool, because then you can say, well, why is this the case? Well, Sweden had treatment restrictions until recently, reimbursement restrictions. You're probably not so familiar with that in France, but the rest of Europe has had these reimbursement restrictions related to fibrosis stage or drug user status. Denmark just removed their restrictions in November 2018. Belgium moved their restrictions as of 1st of January 2019. So until then, it was a tough sell. We need to eliminate hepatitis C. Come and get tested. Your fibrosis stage isn't serious enough. Wait. So that's been, and then the word gets around, why even go get tested in the first place for certain populations. So now restrictions have been removed in most of Western Europe. They're in place in most of Central and Eastern Europe and some other countries around the world. So I mentioned the importance of a health systems approach. And here on the left, you see the 6 building blocks as WHO puts them forward. And then you see these interim goals that WHO has, that I call the public health challenges. And particularly access and coverage are important for hepatitis C. And then the ultimate goal of any health system, improved health. And WHO back in 2007 said level and equity. So by level, if we apply this to hepatitis C, this means those earlier targets I mentioned, the 80%, the 90%. We want to reach those. But if we take the proper definition of a health system outcome, we would apply equity. And we'd say we need to apply that to each population. So if you're not reaching those targets among prisoners, among migrants, among people who inject drugs, then you can't really be said to have eliminated hepatitis C. So we think that that continuum of care should be done at the national level, by regions, by cities, but also by populations. And we see some countries starting to do that and obviously showing much worse outcomes in more marginalized populations, like people who inject drugs. Later, we rejigged the health system framework that WHO had and added in patient engagement and communication, which were really lacking, at least from the sort of theoretical perspective. How do we engage with patients? Patients actually drafted those two WHO resolutions earlier on. It's not a well-known story, but they worked together with the governments of Brazil, Norway, and others, and they prepared those first drafts. They held the first World Hepatitis Day, and I think they are key to eliminating both patient groups and groups representing risk populations. WHO then went one step further and a few years ago released their framework of a people-centered health systems approach. We've been talking about it a lot, but now they at least gave us the image of showing sort of the dynamic interaction between different parts of the health system. How can we use that? Well, in the case of hepatitis, we can start asking questions like, in terms of leadership and governance, we can ask, were clinicians involved in developing the strategy? Were patients involved? Seems obvious, but in Spain, the great 60-page strategy that came out 5 years ago didn't involve clinicians, didn't involve the populations, and it led to major protests, patients chaining themselves to doors because it didn't allow for them, because there were still treatment restrictions, clinicians opposing the elimination strategy or the hepatitis strategy of Spain. So you can start to ask, and we've developed this a bit further as I'll show you, but a whole series of questions to see if you're ready, if you're sort of fit for purpose to eliminate hepatitis C. Do you have the right workforce? So we have specialists in hospitals, but you have addiction specialists, you have nurses outside in community settings who are testing, who are able to provide treatment. And I'm going to show you some examples of models of care from other parts of Europe where this is starting to take place, albeit quite slowly, but I think that's the only way we can engage the most difficult to reach populations. We've been asking a lot about the budget, and of course with the high costs for treatment, that's been a major issue. Now we're finding big challenges related to getting the diagnostics, to buying the gene experts, to getting enough rapid tests in place. Do we have the capacity to monitor both at the patient level but also surveillance in general? And do we have strategies in place for engaging all of the affected populations? Are your hepatologists engaging with your nephrologists? Who's reaching out to those co-infected with hemophilia? What's the relationship with the addiction centers? So on and so forth. And finally, are we able to collect and analyze and use all of this information? Important for us as researchers, and do we have proper feedback loops for the authorities that will take the ultimate decisions? So what we did was take that one step further last year and start to develop a model that looked at marginalized populations at high risk of vulnerability, not necessarily just hepatitis, but in general for mental health issues, for infectious diseases. And we made a checklist. So it's starting with those questions I asked that I used to use before. We then sort of scientifically, together with the European Commission and others, made a whole list of questions, and let me go further, that we can ask to see if your system is people-centered as set out by WHO and by the experts involved in developing this tool. So this is really also from the community perspective. Were community representatives involved in the design of the service? What kinds of barriers were identified by the community? How will they be overcome? The design considerations, so on and so forth. That will hopefully be coming out in WHO Bulletin later this year, but we think that we really need to look more carefully at the health system in terms of reaching elimination. I leave this here just to show you how much has changed in the last year and a half across Europe. So I mentioned that the reimbursement restrictions that were in place, and you can see basically France, Spain in 2017, Germany without restrictions, but all of the Nordic countries, the Baltic, Central and Eastern Europe, had restrictions in place. Huge barriers. Restrictions typically in place because of the high cost of treatment. As that has fallen, restrictions have been removed, but not in all countries. So since November 2017, just a year and a half ago, here's a list of countries that have removed their restrictions, and we start to see people getting treated much quicker, but that doesn't really resolve the left side of the cascade related to testing and diagnosis, which I'm going to come back to in a moment. I mentioned also that, I don't know how many of you are active clinicians, but surely if you've diagnosed 10, 20, 100 people with hepatitis C, some of them have presented late. Late defined as arriving with an F3 or an F4, or you can read the article for more details with the APRI scores and so on. So we think late presentation is a big problem. We know it's a big problem with HIV, where we're still using the cutoff rate of a CD4 cell count of 350. The same group, adding in some hepatologists working with EASL, went on to present this consensus definition of late presentation. When I've met with certain hospitals, they've said, well, that's really not a problem here. And we ask, well, how do you know that? And they haven't looked carefully at the data. So we just put together this Excel that's right now we're using in 8 regions of Spain, in 11 hospitals in 8 regions of Spain. And we're finding around 20% of people who presented for the first time at a hospital with hepatitis C arrived late. So this is, and we're up to around 1,200 cases. So these are big numbers. We think probably more generalizable than just those 1,200. So big numbers of people who are arriving late for care, which in our public health systems is frankly a disaster. So we need to be reaching people earlier, providing them with the treatment, both to prevent onward transmission, but also to prevent this kind of late transmission. So I can always send you this Excel, and we're working on increasing this to a European level study. The Germans have done it, the Scots have done it, the Slovenes have done it, but it'd be nice to have more countries and some real power, because this is important advocacy for why we need to test more, not just to reach some targets set by the World Health Organization, but in order to prevent or end people arriving late when they come for the first time for a test at our hospitals and clinics. One of the big issues if we start to move into the elimination era, obviously with PEG interferon, things were quite different in the numbers of visits and the kind of care you needed. So the models of care were very different. Many of those models have continued to today. And here we show just the number of visits to finally get your diagnosis. In many settings is up to 4 or 5 different visits you will need to get a confirmatory diagnosis. And we need to figure out how to reduce this through using dried blood spots, although they're still not, well, basically for regulatory reasons, widespread or used across Europe. They're used a bit in Spain and Scotland. But how can we reduce the number of visits so we end up maybe in some settings with just either one visit with an antibody and an on-site RNA, or for certain populations going straight to RNA. You come in, 1 hour later, you know if you have hepatitis C, and you can start on your treatment. And maybe you don't need to go to a hospital at all. Does this happen in France at all? Where you can just get diagnosed outside of a hospital and treated outside of a hospital?
There is just one project in Paris about these. There are some research projects ongoing.
So these are research projects,
yeah,
ongoing.
It's not ongoing.
Yeah, so big surprise, if you take your pills and you're not in a hospital, they still work. So we can skip, I don't want to take away anyone's future research funding, but we're pretty sure that that's the case. There's been enough pilots now. We need to start scaling this up and operationally figuring out how to do this. So these different kinds of models of care, I mean, we need to look at what's the relationship with prisons. So in the El Dueso prison in the north of Spain, the hepatologist said, well, I've run out of patients, but I know hepatitis C is still a problem. He created a relationship between his university hospital, that prison. They offered a test to everyone in the prison and everyone arriving. Almost everyone accepted. Everyone who was positive started treatment, and taking that medicine in a prison worked. They were all cured, and now they're keeping down to about 0 the numbers of new cases in that particular prison. Across Catalonia, where I'm working, prison doctors can prescribe DAAs. That's not the case in the rest of Spain, certainly not the rest of Europe or the world. So who can prescribe makes a difference. But through that kind of telemedicine, they had cases earlier where prisoners were brought, with 3 or 4 police into the hospital. It was a whole big event, and you have hepatitis, go home or get the test and then come back and get the results. None of that is really needed anymore. You can send the rapid tests, you can send the gene expert, or you can send the blood to the lab from the prison. You can send the medicines over there. But these are health systems issues, and I'm going to give you an example from Copenhagen of where it took us 2 years in this little city in a little country to overcome those challenges and start providing testing and treatment outside of the hospitals. Harm reduction centers, community health centers, even GPs, like in England and parts of Germany, can all be involved in the testing and in the prescribing and in the treatment if relevant for certain populations. So this is the Shared Addiction Care Copenhagen program that our university hospital, the one I actually just left, runs. So here on the left you would see the addiction center, the lab, our university hospital, and the poor patient, someone who injects drugs, running all around, getting an appointment, going somewhere else to give the blood, coming back, getting an appointment, going back for the results, maybe doing the antibody. We don't always have reflex testing, then going back for the RNA, and we would have this typical 5 visits to get your results. So taking a people-centered health systems approach, we simply said, what would you like to do? How would you like to be diagnosed and treated? And they said, well, we don't really want to go to the lab at all, even if it's in the hospital. And actually, we don't even want to go to the hospital at all. We just want to go to our addiction center, do our thing, and get a test there. And if we need medicine, let the medicine arrive there. So 2 years later, the government, the municipal government of Copenhagen, our hospital, the addiction centers all agreed that we will do this. We take the portable FibroScan there because some people still feel you have to FibroScan before you can treat the hepatitis C. FibroScan is a luxury. It's nice. We should do it when we can, but it shouldn't get in the way of treating and ultimately eliminating hepatitis C. And so we do everything in the addiction center. That begs the question about all the people who inject drugs who don't go to an addiction center. Copenhagen has 15 addiction centers. I did a tour of 3 or 4 of them earlier this week and took some photos that are here. Photos that are not here. But these photos are from our response, was that if drug users don't want to go to the addiction centers, we should be able to find a place to test them. So this is the Gene Expert that we bought. Is everyone familiar with the Gene Expert? It's well known in HIV. It's a small machine, costs around 20,000 euros, has 2 little boxes here and a computer. You type in the information, it says open box 1 or open box 2. It's pretty easy. If box 1's busy, it tells you to open box 2. You put the little capsule with the blood in, 58 minutes, it says, here's the answer. Confirmed RNA or not. Based on that, you can prescribe. So this is inside, as I'll show you where this is in a moment. This is what it looks like. The box, you jab the finger, take out a little blood. This is the head of the infectious diseases department at the university hospital, who had never seen this before, getting her test. See how easy it is? This is a nurse in training doing this. Pretty easy to take blood. And all of this is happening in a van parked in Denmark's largest open injecting area, which is basically behind the main train station. So this building right behind here has all sorts of facilities for drug users, including outdoor sort of plexiglass boxes where you can stand and smoke and get out of the rain, because it rains there every day. And then if you want, you just come over to the van where you can see it better here. The Users Academy, so these are peers. The van is paid for by the government of Copenhagen. The peers run everything. And if you're positive, we still have to genotype because MSD came in so low with their medicine. There's a huge price differential between the treatments that'll probably end in the next round of pricing. But we genotype, and then the medicines can come to the van, or you can go to the hospital. If you can't find your way to the hospital, the peers will drive you. When I was there earlier this week, a couple of the homeless people didn't have telephones, and they've been collecting old phones and gave them to the homeless so they could call them to remind them to take their medicine every day, and they get sort of a week or 2 weeks of medicine at the time. And it's been a real rallying point for drug user health in general, because they like getting this care and this attention and being able to cure something. Many of them had been on peg interferon or know people who have, and now they see how easy it is. So the word is spreading, and this van, of course, is also mobile, so it now moves around to other sites. So this is a project we started in April, led by the users in collaboration with me and the University Hospital's chief infectious disease doctor. We have a gene expert in the van, and we have linkage to care at the hospital. It's not very expensive. It's not very complicated. The hospital agreed that if we call in advance, when the drug user comes, they will see them and do all tests and FibroScan at the same time. Because earlier, you had to get an appointment for the FibroScan, appointment for the blood, back and forth and back and forth. So it might have taken 5 tests to get the diagnosis, but then there were even more visits just to get that initial treatment. So we've reduced that to sort of TNT, which in English means dynamite. So we've put an explosion into the Danish health system with this little van behind the main train station. If you go to Copenhagen, go check it out. Another place you can work on elimination is in pharmacies. So there's a project in 8 pharmacies in Birmingham and Manchester where they've placed gene experts, and there the pharmacists will run the same test for hepatitis C. That started last July, and basically this is what it looks like. This is the minivet. You put the blood in here. You put the blood in this capsule cartridge into the machine, and probably your hospital has a big stationary gene expert, often with 128 capsules at the same time. But here, in 58 minutes, it's only been on the market since September, so it's not really widely used. We have just one in Denmark, but in 1 hour, you get your results in this case, at the pharmacy. And then, oops, I cut that out, sorry. But then the pharmacist has a whole pathway, and if it's positive, they will inform your GP, and your GP in England can prescribe. You never need to go to the hospital unless your GP is based there. And you never need to see a specialist unless there's some other mitigating factor, like a co-infection or they've detected liver damage. This is a project we have in Barcelona. This is La Mina. Many of you, if you've been to Barcelona, have just driven past this, but right behind it is a pretty rough neighborhood with drug users, pretty dangerous and violent, the side of Barcelona tourists never see. And here's a safe injection room. There are 7 main harm reduction sites in Barcelona. This is a fully refurbished by the government, very clean, very nice harm reduction center. They were doing antibody tests there and then taking the drug users to the hospital. And most drug users never really made that journey to the hospital, because when you went, you got an appointment to come back, and that just didn't happen, and they didn't have the resources at the harm reduction center to do this. So we installed a gene expert there last year. It was still a pilot, so it was a researcher machine. We tested 100 people. We checked it against blood drawn in the laboratory and tested at the laboratory, because it was part of a pilot test to show that these machines actually work. I won't go through all the results, but it's been presented at a few conferences. But we did DBS, we did the gene expert, the RNA, we did the antibody, and ultimately we were also looking at things like how many people do we lose if we do DBS and they have to come back for their results, compared to how many people will stay if we do the on-site RNA. We had small, let's say, tricks to keep people waiting around for an hour, like a muffin and a coffee in a room with a sofa with some board games. Well, if it were Copenhagen, it would work great because it's raining all the time. Of course, in Barcelona, people go outside again. But people tended to stay, and they wanted to know. And we kind of built a momentum with peers saying, do you know? Have you gotten the test? And they come and they stay, and muffins and coffee don't really cost anything. But so this is a little more complicated. But essentially, we did the DBS study. So now DBS can only be done at this one laboratory in Barcelona. That's the only place in Spain that it's legal. We have the gene expert there, and we're starting to expand this. So there's a van going around Madrid, also with the gene expert. And then we have a new project where a specialist liver nurse goes to this harm reduction center, can verify the test results, and provide the treatment without the patients needing to go to that hospital. So for a long time, we didn't have that linkage to care, so it was a very challenging project. We're testing, and we're basically just losing everyone. Now we can finally, with the University Hospital, the Hospital Clinic, link to care. So I know I'm probably starting to run out of time, yes? Okay, 5 minutes. So to start to end sort of this elimination story, we were so excited when WHO called for elimination. Finally, I'd been there 11 years, nothing was really happening. I leave, they call for elimination. And the response from countries was, let's say, a muted enthusiasm, with many countries saying this is going to be very challenging, it's going to be very costly, it's a complex issue. As I've shown, it took a couple years just in Copenhagen or over a year in Barcelona to figure out how to test, which tests you can do on site, how to link to care. But there's more and more of these new models of care being piloted, being confirmed, and slowly being scaled up. But during that time, the EASL International Liver Foundation, where I sit as vice chair, came up with this concept of micro-elimination. We don't want to reduce efforts for full elimination, but we said, why not start thinking about particular populations? So the decompensated cirrhotics, that's obvious, they're already almost all in our care, or will be very soon. So we treat those. But what about patients with hemophilia? Well, in Ireland, the Patient Association wrote to everyone with hemophilia, because they're almost all members of the Patient Association, and said, get a hepatitis C test. Almost everyone did, and everyone who was positive was treated. End of the problem there. End of the problem in Slovenia. CKD, when I hear that there are people on dialysis with hepatitis C in European hospitals, I don't know what's going on. Why are they not getting their hepatitis C treatment? We end that story. When it happened in our hospital, the nephrologists were so happy. I mean, that was just one less thing to be thinking about, one less machine dedicated to that population. We just test people now before they start on a machine. Transplant patients, both donors and recipients, we know who they are, get them all tested. Then it becomes more complicated with other populations. The US has gone after veterans because they have a parallel Veterans Administration set of hospitals. PWID, we can break that down to those who are on opioid substitution therapy, and I know Patricia and her group are researching, and there's differences between females and males, etc. But those who are on OST should be easy to test and treat. Those going to needle and syringe programs, like in our Barcelona project, a little more complicated, but still, it tends to be the same people coming back every day or every couple of days. That's an easier population to reach. Those co-infected with HIV and on antiretroviral therapy, there's no reason they shouldn't all be tested and treated. They're coming to see us every 3 months or 6 months or 12 months, depending on how your system's organized, for their regular checkups, their new prescriptions, and to pick up their medications. And of course, prisoners, well, if they're in prison longer than 48 hours, we know where they are, so this is a good place to test and treat. It can be hard with the judiciary system not collaborating with the health system, hard to get the funding in place, but we are starting to see some prison populations being addressed. It's an important population because for some prisoners, it will be their only encounter with the health system when they finally go to prison. Otherwise, they're outside of the health system. So it's important to reach them there if we want to eliminate. I won't go through all the operational work we've developed, but basically what we say is that it's truly microelimination, not just when you've dealt with 100 co-infected hemophiliacs or 10 people on dialysis, but when you have a plan, when you have targets, when it's a multi-stakeholder effort, and when you have continuing monitoring. So we published this last year to kind of put out there how you can actually fully develop microelimination, because everyone was running around saying, we've eliminated, all 2 people over in the center got treated, that's fantastic, but we need to look at how to monitor it and scale it up as well. So as I start to conclude, I'll go back to this people-centered health systems approach. I think that's the only way we're going to be able to deal with the elimination of hepatitis C. We can't just sit in the hospitals and wait for people to come to them. In fact, when we call it late presentation, the idea is that they're presenting late to us with hepatitis C, now we're starting to call it late diagnosis. We're diagnosing them late, and we need to sort of turn around the dialogue and the narrative and think about who are the populations we're trying to reach: marginalized populations, vulnerable populations, or certain age cohorts who simply don't know anything about hepatitis and don't know that they could be at risk because they might have had a blood transfusion before 1989. So in the end, we really need all of these different populations working together. And I know in France and most of Europe now we've had national meetings and regional and city meetings with the different stakeholders to make those plans and to make them more operational. So let me end on that, and I think we have maybe 5 or 10 minutes for discussion or questions. So thank you.
Thank you.